Okay, all right. So let's begin. So to welcome everyone to join the session for this evening. Today I'm very honored and also pleasure to invite my close friend Yi Hong, we call it Dr. Lee, to help us conduct this session. So it's going to be the same rules. So if anyone have any question, so we will after each scenario we will have a discussion. Okay, so Yihong, you are ready?
Hello, yeah. Can you hear me?
Yes, I can hear you.
All right.
So you want to begin?
Yeah, okay.
Okay, all right. I think the format everyone is familiar, so we will skip this part. So perhaps let you start with the first case. First case is I think Aaron, right? Aaron, are you there?
Yep, doctor, here.
Okay, all right. So, Dr. Lee will be your surrogate as well as your examiner. So you have 5 minutes to prepare. So I will do the timekeeping. Is it okay?
Fine.
Okay. All right. So let's start. We'll give you 4 minutes as usual.
You mean your slide?
Doctor, I can't see the slides yet.
Can you see now?
Yeah,
Yeah.
can see.
Okay.
Thanks.
All right. So we start the timer for you. Okay. 4 minutes. You can start now. Okay, time's up. Dr. Aaron, this is the patient, Mrs. Elizabeth. You may begin.
Hi, good morning, Mrs. Elizabeth. My name is Dr. Aaron. I'm in the doctor in the outpatient clinic today. Can I confirm that you're Mrs. Elizabeth and you're 60 years old?
Yeah, I'm Mrs. Elizabeth and I'm 60.
I've been hearing that you have some problem with joint pains. Can you tell me more about this?
Yeah, doctor, actually I've been having this joint pain. Usually initially it started on my wrist. Subsequently, all my fingers actually has been having a similar problem as well for the past 6 weeks.
Okay, and did it come on suddenly or over a day, or is it gradually getting worse?
I think it's actually gradually getting worse.
Okay, and is there anywhere else that you have a joint pain?
So far, the most painful joint that I experienced is actually my right wrist, and subsequently my left wrist and all part of my fingers as well. Other than that, no other joints that I'm aware of.
Any part of the day that it comes on for this joint pain, like in morning or at night?
Yeah, I realized that in the morning, usually it actually become worse, but
I
as
see.
day goes by, it actually improve.
Okay, and anything that helps with this pain?
I actually took some painkiller and actually it improved.
I see. Okay, and anything that worsens this pain?
Not that I'm actually quite aware of.
Okay, and do you know the name of the painkillers that you took?
I actually took celecoxib, Celebrex, if I'm not mistaken.
Okay, and is there any associated stiffness with this pain?
Oh yeah, especially when I wakes up in the morning.
I see. How long does the stiffness last?
For the past 1 week, it actually getting longer from initially probably a few minutes. Now in the morning, about more than half an hour that I usually have the stiffness.
Oh dear, that must be troubling to you. And how has it affected your function?
Oh, definitely, because you see, I likes gardening, and usually when I like to garden after I wake up in the morning, so it really does affect my hobbies.
Okay, and I hope that after this consultation, we'll be able to help you with this.
All right,
Just to ask you a few questions, do you notice any rash over any parts of your bodies?
rash. Not that I aware of.
Okay, and do you notice any mouth ulcers?
No,
Okay, and do you notice any tightening around your fingers or your mouth?
no,
Okay, and do you have any troubles with swallowing?
no.
Any hair loss?
I do have some hair loss, but I think it's probably due to aging.
I see, and you don't wake up with your bed covered with hair.
Oh no, 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 definitely no.
Okay, and any fevers recently?
No, you mean feverish? No.
Okay, and do you have any troubles with swallowing?
I think just now you mentioned yeah, no, no problem with my swallowing.
Any redness of dry eyes?
No,
Okay, and any recent changes in your weight?
my weight has been rather static.
Okay, and do you notice any change in your appetite?
My appetite has been good all the while.
Okay, do you notice any lumps or bumps anywhere in your body?
Oh, I do have a neck swelling because I have this condition called grave disease. So I do have the neck swelling for many years.
I see, and has it been the same or has it increased recently?
It has been the same.
Okay, all right. And do you have any hand tremors?
What do you mean by tremors, doctor?
Sorry, any hand shakiness?
No.
And do you have any diarrhea?
No.
Uh, and any sweating?
No.
Okay. And also, do you have any constipation or difficulty in passing motion?
No.
Okay. And um, do you feel more anxious recently?
No, not that I'm aware of.
Do you feel your heart beating out of your chest?
No.
Okay. And do you have any shortness of breath?
No.
Do you have any cough?
Occasionally,
I see. And when has this cough started?
it has been more than a month, but I actually doesn't have any sputum or phlegm. It's just some occasional cough in the morning.
I see. And do you cough out any blood before?
No.
Okay. Any leg swelling?
No.
Uh, and any feeling of dizziness?
No.
And do you feel any chest pain at all?
No.
Okay. And do you feel any numbness in your hands or your legs?
I feel whenever I have the stiffness, I actually feel that my hand are numb.
Okay. And does your hand changes color to blue or white when exposed to cold area?
No, not that I actually experienced before. No.
Okay. Is the numbness worse at any point of in the time of day, like at night?
Oh no.
Okay. All right. And just to ask every patient, do you have any discharge from your private parts?
No.
And do you have any foul smelling urine, smelly urine?
No.
Any passing out excessive urine or feel the urge to urinate?
No.
Okay. Do you have any pain in other parts of your body, like for example your back?
No.
Okay. And do you have any muscle aches that you feel in your maybe your shoulders or your thighs?
No.
Do you feel weak like climbing upstairs?
No.
No. Okay. All right. And just to ask a bit about your past medical history, you mentioned that you have Graves' disease. Do you have any other medical conditions?
Um. So far, I only have Graves' disease.
And is your Graves' disease under follow-up?
Yeah, I'm actually under endocrinologist follow-up.
And what medications are you on?
I'm actually on this medication called carbimazole.
Okay, how much do you take for the carbimazole?
I'm taking 2 tablets every day.
Okay, is there any recent change in the dose of your medication?
It has been rather static for the past 2 years, the dosage of the medication.
And is your thyroid function levels controlled from your last visit?
Yeah, my doctors told me that everything looks good.
Okay. And a question we ask every patient, do you have any allergies at all?
No.
Do you take any recreational drugs or any over-the-counter medication?
Uh, just the painkiller that I mentioned just now.
Okay. Any traditional medication?
No.
Okay. A question we ask every patient, have you ever smoked?
No.
And do you drink alcohol at all?
Occasionally during festive season,
Mm. Okay. And how much do you drink and how often?
probably 1 month, once or twice, maybe 1 or 2 glasses of wine.
Okay. All right. And can I know, do you still work or are you
Oh,
retired?
I'm a retired clerk.
Okay. Can I quickly examine you?
Oh, sure.
Okay. So just gonna look at the patient for the general body habitus. Is she overweight or underweight?
She is of normal build.
Okay, and looking at the eyes, is there any proptosis or
No
chemosis?
proptosis, no chemosis, no thyroid eye sign.
Can I look at the hands to check for any tremors or any clubbing?
No tremors, no clubbing.
Okay, and I'm just gonna palpate, ask the patient, do you have any pain at the moment?
A little bit discomfort on my right wrist.
Okay, so examine, and if there's any pain, please let me know. And I'll examine from the fingers first to palpate for the synovium of the joints of all the phalanges.
Okay.
Is there any synovitis?
There is no tenderness over the DIPJ or PIPJ. There is some deformity as shown on the figures, and there is mild pain, tenderness over the patient right wrist.
Okay, and I'll ask her to hold a pen and try to write.
She can, but with some difficulty. She feel painful
Uh,
when she started writing.
okay, I'll ask her to form a fist to see if she's able to form a fist.
Yes, it can be done. It's normal.
Okay, and ask her to do a prayer sign, and if she's able to do.
Yes, normal.
Okay, and I'm also gonna palpate for the elbow to see if there's any tenderness or synovitis.
Elbow is no tenderness, no nodule as well.
Looking for any rash also, any psoriatic rash,
Such as
uh, any psoriatic rash over the elbow, and then elbow first.
no, no additional skin rashes.
Looking at the scalp for any dandruffs or any psoriatic rash.
No,
Any red eyes,
no,
any uh, any uh, gouty tophi over the ears.
no,
Okay, and also checking for the umbilicus for any psoriatic rash also.
no,
And over the back, got any psoriatic rash?
no.
Okay, and I'm going to listen over the lungs bases to hear for any crepitations.
The lungs are clear.
Okay, listen to the heart for any murmur.
No murmur.
2 minutes left.
Okay, and also look for the legs for any pedal edema and any psoriatic rash.
No pedal edema. No psoriatic rash.
Okay, Mrs. Elizabeth, do you have any concerns at this moment?
Yes, doctor. Is my joint condition related to my grave disease?
As of what I've examined you today, I feel that it is not related to your Graves' disease. It is another condition, what we call as rheumatoid arthritis. So it is also a autoimmune condition in which your body actually attacks your own cells, but in this case, it's towards your joints and causing you to have all these symptoms.
I see. You mean my this rheumatoid arthritis is not related to grave disease?
Yes, I do not think that it is related to Graves' disease.
Okay. So is this condition inherited?
This condition is not inherited directly. However, there is an increased chance of you having this disease if your family actually has any autoimmune conditions. But just to check back, does your family have any conditions that run in your family?
Yeah, actually, my family have most of my siblings actually have this thyroid problem.
I see. Okay. And their thyroid is high?
Yeah, they are all
Okay.
most of them actually have this grave disease.
Okay. All right.
Hmm.
Do you have any other concerns?
Yeah, as for my fingers, you see they are actually quite deformed and it looks so ugly. So is the deformity reversible?
Unfortunately, most of the deformity
Time's
is
up.
not reversible. Yeah.
All right. Thank you very much. So yeah, Dr. Aaron, what do you think? I think it's my question time. So what is the likely diagnosis for this lady?
My primary diagnosis for this lady will be rheumatoid arthritis
All right.
because she presents, yeah,
What
because
is
she's presents
your
with
differential diagnosis?
my differential diagnosis can be a paraneoplastic syndrome causing all
Secondary
these pain,
to
secondary to uh, a malignancy. However, in this case, she does not have any signs of or symptoms to suggest of malignancy.
what are the more possible differential diagnosis that this lady could have?
It can be also osteoarthritis. However, she
Okay,
presents more with inflammatory joint pain.
good. What else?
Can be psoriatic arthritis also.
But
But
so far she doesn't have any rash yet. Yeah, okay, it's not wrong because some of them might not have the skin lesion. Okay, all right. So how would you investigate this lady?
so I'd like to send off full blood count,
Mm-hmm,
renal profile, as well as liver function test. I would
mm-hmm,
like to send for off inflammatory markers such as CRP and also ESR.
mm-hmm,
And I'll send off ANA as well to look for autoimmune diseases and rheumatoid factor.
uh-huh,
And as well, I'd like to send off C3, C4,
uh-huh,
and I'd like to send off tumor markers as well. Uh,
mm-hmm,
and besides that, I'd like to do an X-ray of the hands
mm-hmm.
and um, and also ultrasound of the joint if there is to look for any synovial swelling.
Okay. So if at all it is a rheumatoid arthritis, how would you like to manage her?
Uh, so I would like to involve a multidisciplinary team focusing on patients' education and
All right.
also counseling. I'll refer her to a rheumatology. She needs to be followed up under a rheumatologist,
All right.
and also refer her to physiotherapists and also occupational therapists.
Mm,
Um, so for the joint pains, for rheumatoid arthritis, we would use steroids to reduce the swelling and the inflammation, and then she will need to be started also on a disease modifying agent, likely with methotrexate first, and other agents to be considered if the pain is still not well controlled. But besides that, also I would like to take a viral screening for her before starting on all this medication.
do you think she warrants a steroid?
Because she has active synovitis over the right wrist, so we also can actually consider uh, joint injection if it's only a single joint.
Mm-hmm.
However, if it's multiple joint, then she will require a steroid,
You mean intra-articular?
intra-articular steroids. Yeah. Uh, if she is multiple joints, then she will need systemic steroids.
Given that the deformity that was shown in the picture just now, what do you think of her disease of the rheumatoid arthritis? What do you think?
Most of the
How active is it?
most of the disease have actually burnt out in the finger with the deformities,
Mm-hmm.
the ulnar deviation and also the swan neck deformities. However, because of the pain in the right wrist, so I would like to look at the blood investigation and the ultrasound findings to see whether there's any active synovitis.
Mm. Okay. Anything else? Any other blood parameter you would like to take for her?
Mm. I also like to send off ENA also to after the ANA to look for any signs of other connective tissue disease.
Okay. Okay. So do you know any oral biologic therapy for her for rheumatoid arthritis that is approved?
Biologic therapies.
All right, it's okay.
Not very
So,
sure.
okay, if I tell you that, oh, just now actually patient asked you whether rheumatoid arthritis is related to the Graves' disease, and
I'm sorry, but you can continue.
okay, it's okay. So, Dr. Aaron, how do you feel?
I felt that I missed out a lot of points on examination and also history lah.
I think to me your first part looks okay, but you are quite rather systematic, and I actually don't have the feeling of you asking me like very systemic review. You mean you know the by organs or by system. So that point I think is quite good. I am quite grateful that you actually remember to ask the family history in the end. Luckily, you remember to ask the family history. Yes, you do miss some point for the history taking, and you do miss some physical examination, which is quite important as well. And for the question, yeah. So let's see what are the important things that you need to actually know. So before that, let me give you the marks first. So for clinical communication skill, there is no problem. I think you elicit the history relevant to the complaint, and you actually explain the information all to the patient. So which is quite good. I will give you a satisfactory for that. But for your physical examination, one very important thing is that did you examine the neck?
No, I didn't examine that.
Yeah, because this lady got Graves' disease. Even though she's telling you that, yes, doctor, my thyroid function has been rather normal, but there is something so obvious from the physical from the picture, which is the neck swelling. So you like it or not, you still need to examine it. Yeah, understand?
Yep.
So I think that is something that is quite important. Um,
Yep.
and when you examine the fingers, I think it will be better if you can tell the examiner what kind of deformity is it. Because I think the hand is very obvious. There is ulnar deviation, there is all the butanial, there is all the all the swan neck deformity also. I think it is quite important for you to mention it. And I think you can see some wasting also lah. It's quite obvious lah, the wasting. So your physical examination is incomplete. For that, I have to give you a borderline because you miss out a few important things, plus a proximal myopathy. Even though you mentioned that you in your history, you asked about going upstairs, but thyroid itself can cause proximal myopathy, even RA itself can cause proximal myopathy. So you need to examine it. But I'm quite grateful that you actually asked for the functionality of the hand by asking a patient to write the name and also make a fist, which is something quite good. And for your clinical judgment, investigation wise, rather okay, but there is other blood that you actually miss out also. Again, Graves' disease. So you need to take
TFTs.
yes, because I will tell you why it's important. It's because RA is actually somehow related to Graves' disease and vice versa. There is a connection. So if a patient have a rheumatoid arthritis, they are at a higher risk of developing Graves. And if they are actually having Graves' disease, they actually have higher chance of developing rheumatoid arthritis. And if either one of the condition is not well controlled, the other condition will be difficult to control, more difficult to control. That's why you need to take a TFT. And it is something you cannot miss because the neck swelling is there, is so huge. So you cannot miss it also. Yeah. So and ENA C3 C4 okay, it's quite obvious it's a RA, right? So plus minus, you might not want to take it. If you want to take it, it's okay. I wouldn't penalize, but there is something else more specific for rheumatoid arthritis.
Sorry, anti-CCP.
Yes. So you didn't mention anti-CCP also. That is something very important also. So another thing also for your imaging, You did mention X-ray of the hands and fingers. So what else you want to send? What else, what other images beside, and also the ultrasound of the fingers and the wrist? You can actually order ultrasound of the neck, right?
Oh, yeah.
Yeah, I think you kind of like forget when you examine, you kind of like forget the grave part, grave disease part. You focus all on the rheumatoid. That's why part of it you actually, I think you maybe 50-50 forget about the grave already. So that's why you focus a lot on the imaging and also the investigation for the joint only. So for that reason, also borderline. But other than that, the subsequent one is okay, concern, good. There actually another concern, but unfortunately not enough time. But I will still give you satisfactory lah for the concerns. Physical sign, I will have to mark you down for borderline because you miss the thyroid physical sign. And differential diagnosis, I will give you satisfactory lah. But actually, I'm not sure why you keep on thinking about psoriatic arthritis. Probably this age group is less likely to be psoriatic arthritis. It tends to be younger patient. This patient is 60 years old. So I will be grateful if you can tell me the differential is osteoarthritis because again, at the beginning, the patient did mention that she likes gardening. Okay. Number two, she is a retired clerk. So a clerk use a lot of fingers for typing. So you need to think of rheumatoid, osteoarthritis, and also another differential that I actually hope that you can tell is actually pseudo gout. But given that the hypermetabolism disease, such for grave disease, there is higher chance of them developing pseudo gout. So I think that one is something that you should take note lah. Then maintaining patient welfare, I will give you satisfactory lah. So in general, I think you did quite okay, but there are actually room for improvement. Some you like to use a few jargons also like tremors. So something that try to avoid. Yeah. So let's go to the next slide to see what is important. Jimmy, can you make the slide bigger? I think you share as a small slide. Okay. So the history important is positive one is multiple small joint pain for it's not 6 months, it's actually 6 weeks. Early morning stiffness and it gets better with analgesia. You didn't ask me about swelling on the joint. That one means it's very important joint pain, tenderness, swelling, deformity. I know it's a sign, but you can ask also. Swelling is something that I can tell you. And grave disease on treatment, and patient has strong family history of grave disease. Family history, because of course, it's already a proven grave, so I wouldn't expect you to tell me all the auto antibody for the grave. That one no need. That one is the main focus is actually the rheumatoid arthritis. The negative history will be no trauma. I couldn't remember. Did you ask about trauma?
No, I didn't.
Yeah, that's why it's very important. The trauma part is actually very important. If you miss this, some examiner can be very cruel. They might actually mark you down also. Your history might get borderline also. Then CTD symptom, you ask me a lot lah. Alopecia, mouth ulcer, rashes. But you didn't ask about photophobia, if I'm not mistaken. Then and photosensitivity rash also. Then constitutional symptom, yes, good. Loss of weight, loss of appetite. And clinically, patient is euthyroid. You spend a lot of time in asking me about the thyroid status, but you didn't ask me about the obstructive symptom from the thyroid. So obstructive symptom, you need to ask very quickly any hoarseness, any difficulty in swallowing. Good as in you ask difficulty in swallowing, but I don't think it's for the thyroid. I think is you are asking about for dysphagia, for the CTD related. Then you need to ask me about shortness of breath lah. So this is something quite important now. So in this history, I think there are a lot that you can ask. So try to be more focused than asking all this. And I think your pace can be faster, slightly faster, because this patient got a lot of things to tell you. Okay. Then social history, retired clerk, and she likes gardening. So for examination, you need to examine the hands. all small joint, including the function. And actually, I put here proximal myopathy. And the neck swelling, yes, please don't forget to at least you palpate the neck swelling and listen for any bruit and quickly check the pulses to look for any evidence of AF lah. So the differential, as mentioned, RA, OA, pseudo-gout. And investigation wise, as mentioned, then management wise, yes, analgesia and edema, and you need to ensure patient is actually clinically and biochemically is euthyroid, because like I mentioned, if this grave disease poorly controlled, you can actually affect the treatment and effectiveness of your medication for the rheumatoid arthritis and vice versa. Then physiotherapy and occupational therapies, because I think the patient keep reminding you, I actually like gardening, so something that she likes and she can't actually enjoy it. So I think occupational therapy and physiotherapy play an important role here also. So for the concerns, is my joint related to my grave? Probably, I think you say no, but I wouldn't actually penalize you, because actually a lot of people don't know also, but it's actually related. It can be related. If you already tell the diagnosis is rheumatoid arthritis, yes, it's related. It can kind of like, I think 30% will have grave will have a rheumatoid, and about 40% of rheumatoid can have graves. Then is it inherited? Good answer. You did mention that it's not really, but you actually have higher chance of getting it if your family have it. Are the deformity reversible? No, definitely no. It's already deformed. So what you can do is actually to prevent it from getting worse. Do I need lifelong medication for the joint? Yes, she need DMARDs, and the choice of the DMARDs is good. You are telling me about methotrexate, and probably you need to read a bit more about the management, the further management for rheumatoid arthritis. Besides methotrexate and also steroid, you got other types. I know you know the answer. Can you tell me more? A few like DMARDs that you know?
Sulfasalazine and hydroxychloroquine, and
Some
also so
leflunomide. Have you
leflunomide. Yeah.
Arawa, all right. So I did ask something about oral biology. Okay, it's not really biology, like it's called TKI. We call it not TKI, JAK inhibitor. Do you know JAK inhibitor?
Oh, yeah, I heard of it.
Do you know which three JAK inhibitor is actually approved for rheumatoid arthritis?
Not too sure.
All right. I wouldn't penalize. It would be good if you can know. You might actually can impress the examiner. It's actually called tofacitinib, upadacitinib, and also baricitinib. All the tinib. All these are actually oral JAK inhibitor, which is is actually proven for RA, PSA, and also AS. So these three is actually available in Malaysia. So yeah. Any questions so far regarding your case? In general, I think you did okay, but you can improve. Yeah. Try to remember what the patient come in. Of course, in real life, if the patient's probably sitting in front of you, you wouldn't remember, you wouldn't forget about the thyroid part lah. I think this part you probably forget about the thyroid when you examine her. Yeah, and during the discussion also. Okay. Any question?
Yeah. No, so far.
All right. Junming, anything you would like to add?
Yeah, just want to add regarding Aaron performance. Just a quick one. I totally agree with what Yu Hong said. First of all, in terms of the history, I think your history is a bit patchy. Although I can see that you try to go systemic, like what Yu Hong said, but it is not very concise, I feel. Because if you go by a approach to joint pain, right, the first question you want to know is perhaps where is the pain, and you must ask the patient to show you. Okay, because if you ask the patient to show you, you immediately see which joint is involved. And sometimes if you ask patient to show you say multiple area, never mind, it's okay, just show one by one. Because when you see which part of the joints, that can also change your differential as you ask further question. So I think to localize the joint to begin with, ask where is the pain, and then whether it's like what Yi Hong say, whether it's actually any swelling, any redness, any deformities, or any for example stiffness. So you ask about all that, then you go by whether this is inflammatory or mechanical joint pain. So I think you need to differentiate this. I can see that you're asking about Socrates and you try to differentiate that, but the pace is very slow. It's very, very slow. You need to show that you are towards which direction, and then you start to focus on there. And then in terms of your systemic review for connective tissue disease, right? I would feel that you need to ask a bit more concise as well. For example, you asked about, still following the Socrates, the last, I did not recall you asked about the pain score. If,
Yeah.
yeah, pain score is another thing that you may want to finish out before you go to systemic review, right? For that particular chief complaint. I think pain score is quite important because you give us a clue that how severe the joint pain and further how actually active the disease. And in terms of the other joint, yes, you asked about neck pain, back pain, and also sometimes you may also ask about whether there's any night pain. After that, then your systemic review can start from head to toe, but bear in mind that don't forget to ask about fever. I don't recall you asked anything about infective symptom other than systemic review. No fever in particular. Fever is important because sometimes you may dealing with what we call as reactive arthritis. Sometimes can be very non-specific and can be seronegative spondylar arthropathy, or sometimes can just be non-specific asymmetrical or symmetrical body arthropathy. So fever is quite important, especially sometimes can also be some form of adult onset steel disease. You won't know until you ask everything until like urine is a negative for everything. Then it is something that you want to put at the back of your mind. So on top of fever, you will start with the hand. You do ask about the scleroderma part, tightness, change in color. That's good. And then go to the head. So you start from the hair, any hair loss, any scalp pain, and then the eye, any redness, any itchiness, any blurring. Do you see double, for example? And then go to the mouth, any mouth sore, any mouth dryness. Go to the face, any rash over your face when exposed under the hot sun, any skin tanning, any change in color. Do you notice any other rash that comes on and off? And then you go to the neck, any bumps or any lumps that you notice, and then go to the chest, any chest pain, any awareness of your heartbeat, any shortness of breath. And then go to the GI part, which is your difficulty to swallow, and then any chest burning sensation, any tummy pain, any change in your bowel habit, any passing of blood in the stool. And then go to the urine, any change in terms of urine amount, and any frothy urine. Frothy is not a jargon. Frothy is just a usual term. You can use frothy urine. Don't know how to use bubble in the urine sometimes. And then because it's a female, so before the female, but you also after the GU, perhaps it's the musculoskeletal. You did ask about proximal muscle weakness. That's good. But you also need to ask about numbness. In particular, in this patient, you want to look for complication. It's not enough to get the diagnosis of rheumatoid arthritis per se. This is a rheumatoid arthritis with quite an advanced manifestation. You want to know whether there's any complication. So one of the complications is perhaps the neuropathy due to carpal tunnel syndrome or some form of amyloidosis. So you want to know whether there's any numbness as well. And then any non-specific pain or numbness over any joint, maybe we'll suggest mononeuritis multiplex as well. And then only you go to hemato. In particular, you want to look for whether any symptoms to suggest anemia. Any previous, if it's a younger lady, I will ask further, do you have any previous history of baby loss or abortion? Do you have any previous blood clot in your leg or any lung, for example? That will rule out APRS part. And then lastly, if you want to screen for other infective symptoms, you may ask about urinary discoloration, itchiness, or even high-risk behavior, for example. And then I think your history is actually okay, I agree, but the pace is very slow. So because I'm a timekeeper, right, I always look at the time. So by 10 minutes, you haven't finished your history yet, actually, before you examine the patient. That can be very dangerous because, like we say, physical examination, you should really spend about 3 to 4 minutes. So, and by the time you reach about the last 2 minutes, which is at 30 minutes, the examination part can easily be spent because a lot of things you want to look for and think along. And another thing that perhaps for all joint station, right, you must make sure that the most important thing whenever examine the patient, yes, look at general condition, okay, but you must sit up the patient properly and you must pass the pillow to the patient, okay, and ask the patient to put both hands on the pillow, okay, and then you just ask patient to relax. Okay, the first thing you want to look is actually, yes, inspection, but you want to know whether this joint is correctable or not. Let's say there's deformity. You want to know whether this is correctable deformity. So how do you do that is actually you ask patient to show the hand, just flatten out the hand on the pillow, whether the joint deformity still persists. If it persists, then it's actually not correctable. So if the joint deformity that's correctable, then you know that you are dealing with Charcot arthropathy. So most of this, like what you mentioned, like pseudogal or RA or OA, those joint deformity is not correctable. So that is also important thing to show. And then after that, you want to check for a look, feel, move, right? And also the functional status, that's fine. And then you also want to quickly go to the elbow, check for any rheumatoid nodules in particularly, and also look for any other thing, for example, patches of rash or any, like what you say, the tophi. And then in particular for this patient, like, because I know that this can be RA or psoriatic actually, because advanced psoriasis also can present like this almost entering like arthritis Mendelian kind of picture. But psoriatic arthritis is something, yes, you want to be listed under the differential is possible, but the clue against is actually there's no rash at all. Okay, so at the same time, you also want to look up from the head to the toe as well. I will spend a bit more time other than examine the head to go to the lung, because I know that in once you want to rule out whether the patient have any evidence of interstitial lung disease like pulmonary fibrosis. That's important, no? And then if you provided a chance, if you feel it's a bit rushed, then you can tell the examiner that I want to complete my examination by looking for abdomen to look for any evidence of hepato or splenomegaly. If you got time, then examiner say why not proceed, then you can proceed. But let's say it's really tight, then you can offer that. Sometimes it's not enough time to finish everything. In this patient in particular, I will also look for renal complication, particularly amyloidosis. So I will actually ask for urine protein, creatinine index, or even like urine protein to screen for any evidence of amyloidosis as well. And then also I will also check for the other joint. And I would say that neck is something very important. You highlighted that sometimes the stem may not be directed to the active problem. Patient may have underlying issues that you also important for you to actually make sure that the underlying issue is also sorted. Like in this patient, perhaps the quick thing to check is to feel for the palm when you check, right? Just to feel for any sweaty palm and also feel for the pulse while you're examining for the joint deformity. That can give you a clue and also show examiner that you're actually assessing thyroid function status as well. Then when you ask the patient to do the range of motion test or anything, you can ask patient to lift up and then just see got any fine tremor or not. Okay. By right, the proper way to check for fine tremor is you must put a paper on top of the wrist when you ask patient to straighten out. So that is the proper method, okay? But if you want to do it separately, then yes, you can examine all the joint, everything, and only then you check for thyroid function is also fine. But the idea is you really need to make sure the status is well controlled, okay? So sometimes RA station expectation can be a lot, especially those common scenario, like they are expecting a lot of things to be done. And I think under the investigation part, I don't recall you remember. I don't recall you mentioned about inflammatory marker like CRP or ESR.
He mentioned.
He mentioned. Oh, he mentioned. Okay. Yeah. That would be good. And I think in terms of the management, right, to actually mention about starting steroid is also a bit controversial, because usually the first line of rheumatoid arthritis, looking at this joint, and if you assess the pain, you don't think the pain is like so bad. Actually, it may not need to start steroid immediately. You can actually start with the first line, which is still the MTX. Okay, so but you can mention that it's not wrong. And then another thing that you perhaps can offer is you can also mention about the role of further DMARD second line, and then followed by biologics therapy. You just mentioned that you don't really need to mention about the name or even the class until the examiner asks you like what Yihong did lah. Okay, and then I can't remember what I want to comment, but generally that is it. I feel your flow is there, but you need to fine tune it until you're like very tuned to the exam. So immediately RA, your brain will be switching to RA as well as looking at the complication. So the presentation method, when you present your finding as well as your examination, investigation, and management, I think can be fine-tuned further. I would say like that. But I think you are good. So just need more practice. Okay?
Yeah.
Yeah.
Thanks.
Probably can proceed. Yeah, thank you. So perhaps can proceed with second scenario, okay?
Yep.
So second is Ben, is it?
Yeah, I'm here.
Yeah, Ben. Okay. All right. So 4 minutes as usual. So we will start the timer now.
Julie, I can't see the case clearly. It's too small.
Can you see? Sorry.
Yeah, I can't see the full screen.
Can't see the full screen.
Yeah, it's a thumbnail.
Can others see? Because
All right.
I actually
I
can.
think I can see now. I can see now. Sorry.
You can
I
see
think
now.
I'm
Okay,
okay.
I will
Yeah.
start timer now. Okay.
All right. Thank you.
Okay, time's up. Dr. Ben, this is the patient. Mr. Wong, you may start now.
Hi, good afternoon. I'm Dr. Ben Cha, one of the doctors in this unit today. Am I speaking to Mr. Wong, 68 years of age?
Yep, and Mr. Wong here.
Okay, hi, Mr. Wong. I can see that your
Yep.
oxygen level is actually on the low side. Is it okay if I give you some oxygen before we continue?
Oh, sure.
All right. Do you feel more comfortable for us to continue?
Yeah, I can
All right.
proceed.
All right. Sure. Thank you. I actually was notified that you're having some tiredness as well as difficult to breathe for the past 2 days. Could you tell me more about that?
Yes, doctor. Actually, since 2 days ago, I started to feel like I have low energy and I feel tired the whole day. Previously, I was not like this, and I had this difficulty to breathe, to catch my breath, which actually started worsening since this morning. That's why I come to the hospital.
I see. That must be very distressing for you. Hopefully, by the end of this consultation, I can provide some help to you. Um, you mentioned to me that you feel low energy. May I know, does
Mm,
it happen all over the day or particular any timing
yeah,
for the tiredness?
it's actually all over the day. I'm getting tired and I'm actually don't feel like getting up from the bed because I just feel very tired.
I see. Does sleep actually help with this?
Oh, not really.
All right. You mentioned to me that you couldn't get off the bed. May I know when you are lying flat, do you feel difficult to breathe?
Not really, but when I try to get up from the bed, I feel slight dizziness.
All right, sure. How long has this dizziness been, Mr. Wong?
Same as the day I start to have tiredness as well.
All right. The dizziness you mentioned to me, do you feel any spinning sensation over your head?
I just feel like when I try to get up, I feel like the surrounding is spinning.
All right.
Yeah.
Do you feel like you're going to throw up?
Oh no.
All right. Or have you actually vomited?
No, I didn't actually vomit.
All right. So come back to this tiredness, the breathlessness sensation. How long has
Mm.
it been already?
The difficulty in breathing also started 2 days ago, but
All right.
started actually after I feel tired. Yeah.
Okay, sure. Um, Other than that, uh, what makes the breathlessness worse actually?
Uh, I feel like whenever I try to get up and also start walking, I will feel more breathless.
All right. Uh, Anything that relieve the breathlessness?
By just lying there and not moving, resting, then I will feel better, slightly better.
Sure. Do you experience any swelling over your legs?
No,
Do you feel you're coughing recently?
no,
Any phlegm?
no,
All right. Do you feel any chest pain?
no,
Have you ever woke up and you felt very breathless over the past few months or so?
no,
Never had that experience. All right, sure. Do you notice you are having some high body temperature or fever?
no,
All right. Do you feel you are sweating at night?
no,
Uh, any problem with the weather? Do you have any preferences over hot or cold weather?
no,
Okay. Do you notice any loss of weight
no,
or any weight gain?
no.
How's your appetite recently?
Since past 2 days actually have been reduced.
All right. Um, Other than that, do you have any pain and aches over your muscles or bone?
No,
Any joint pain?
no.
Do you notice any new rashes?
Rashes? No,
Okay. Any lumps or bumps that you noticed recently?
no.
All right. You're telling me that you are feeling some very low energy. Do you feel that your arms and legs are become weaker?
I just feel generally when I try to get up, I just feel very, very tired. But there is actually not really specific that is weak. It's just feel like I have very little energy. Yeah.
All right. Sure. How is your swallowing? Any problem with
Swallowing?
swallowing food?
No.
Okay. Do you feel any tummy pain?
Yeah, I do actually have some mild discomfort over my stomach area.
All right. Wait, can you point to me by any chance?
Actually middle, a patient point to you at the gastric region.
Gastric region. All right, sure. Has it become worse over days?
It's just getting static. It's not actually getting worse or better.
All right. By any chance that you notice the pain go anywhere?
No.
It just happened at the tummy area, at the upper tummy area.
Yes.
All right. Do you notice any changes in your stool? So sorry to ask.
For past 2 days, I actually has not been passing motion.
Okay. Have you ever noticed that your stool become black prior to this?
Not that I know of, because like I mentioned, past 2 days I have not been passing motion.
Okay. Other than that, do you have a feeling that you want to pass motion?
No.
All right. How's your water works, may I know?
It's normal.
Okay. Do you notice any bubbling?
Bubbling, no.
Are you going to toilet more frequently
No.
or less frequently by
No.
any chance? All right. Any change in color?
No.
Do you notice bleeding from anywhere?
No.
What about nosebleed?
Pardon?
Do you have any nosebleed?
No.
Any gum bleeding?
No.
All right, sure. May I know any medical condition that you were diagnosed with previously?
Yeah, actually I have this condition of irregular heartbeats.
All right.
Yep.
May I know, are you seeing the heart doctor for this?
Yes, I'm actually seeing the doctors, and I'm also on some medication that the doctor told me must continue.
All right. May I know what are those?
I'm actually on bisoprolol,
Okay.
if I'm not mistaken, and also on a blood thinning agent called warfarin.
Okay, sure. Other than that, any recent changes over the doses?
No, my warfarin and the bisoprolol doses has been rather the same.
All right. Did any doctors tell you that your INR are actually within the target?
During my last checkup last month, my INR was actually 2.8.
All right, sure. Other than that, are you taking any other medications?
No.
Are you taking any traditional medication
No.
or any direct sale products,
Not really.
any over-the-counter medications?
No.
Okay. Other than that, besides your irregular heartbeat, do you have any other medical conditions?
No.
All right. Do you have any surgery done for you before?
No.
Any admission to the hospital previously?
Yes, I do have a history of admission to the hospital few years back. The time actually I'm passing out blackish too, and
2 years back.
similarly I feel tired that time as well.
All right, sure. Mr. Wong, is it okay if I examine you and at the same time I'm going to ask some more questions?
All right, sure.
Okay. I would like to have a look on Mrs. Wong, general body habitus. Is he Caucasic by any chance?
No, he's a normal build.
All right. I'm going to have a look on the peripheries, just to have a look on the palms. Is that look pale?
Yes, the palm are pale.
Any clubbing?
No clubbing.
All right. Any stigmata of infective endocarditis?
No.
I try to feel the pulse. How is the pulse volume?
His pulse volume is low and weak, and
Okay.
it's a irregular pulse.
All right. Any collapsing pulse?
No.
I would like to check for. I'm going up to the trunk. I would like to check for any bleeding or any bruises over the body, or
No.
over the arms.
No bruises noted.
Okay. Have a look on the conjunctiva. Is it pale?
He is pale,
Any jaundice?
not jaundice.
All right. I quickly go to the chest and see any scars or any ICD devices.
No.
No. Okay. I want to auscultate the heart for any murmur.
All right. You can notice that there is a pansystolic murmur heard over the mitral region.
All right. Any other murmur?
No other murmur heard.
All right, I would like to go to the back of the patient to listen for any crepitations.
No crepitation.
Okay, I lie back down the patient and to look for to palpate the abdomen,
Okay. There is soft and non-tender, the abdomen.
even on the epigastric region.
Yes.
All right, I would like to perform a character examination to look for any melena.
All right. Examiner tell you that there is a melanix too.
All right, sure. On the other hand, I will also, Mr. Wong, do you have any disease that runs in the family?
Not that I have known of.
Okay. May I know what do you work as previously?
I'm actually unemployed and I'm actually staying alone.
I see. Okay. Are you married by any chance?
Yeah, my partner actually passed away.
Okay, I'm so sorry to hear that.
Yes, yeah.
Yeah. Just would like to ask a few more questions that I ask most of my patients. Hopefully you don't mind. Do you smoke, Mr. Wong?
I was an ex-smoker, but I stopped after my daughter told me that I have this irregular heartbeat.
All right. Do you drink alcohol by any chance?
Recently, no.
Previously, do you regularly
I
drink
was
alcohol?
an alcohol consumer until I was started on this blood thinning agent, and the doctor just tell me, no, you cannot take alcohol.
All right. Were you drinking very heavily?
I used to, but since I'm diagnosed with this irregular heartbeat, I actually stopped drinking.
Sorry, may I know how long ago were you diagnosed with this irregular heartbeat?
Oh, more than 5 years.
More than 5 years. All right. So sorry to ask, do you take any recreational drugs?
No.
All right, sure. Do you have any concern, Mr. Wong?
Yes.
2 minutes
What
left.
what am I happen? What is happening to me actually? Am I
Okay.
getting bleeding again?
Mr. Wong, most likely I think that you're getting another bleed inside your gut again. I'm so sorry to tell you this, but we'll try our best to help you. I think you will need to be admitted to the hospital. I will try to refer you to one of our scope doctors. They'll put a camera. We do a camera test for you, which I will elaborate further later in the ward, and we'll try to look for any bleeding inside your stomach.
All right. You mean I'm
Yeah.
actually having? Why is this bleeding keep happening to me?
All right. At this point of time, I could. There are multiple reasons that this could be happening, and we need to look into this properly while you are in the ward. We also take some blood tests for you, and especially on the INR as well. If it's for long, we will try to give you some of blood products or medication to help you with the bleeding problem. Does it sound all
All
right
right.
to you? Yeah.
Yes. Is there
Do
any
you-
alternative for this to this blood thinning agent?
All right. There are alternatives for this blood thinning agent. Once we have secured the bleeding that you are having at the moment, we can always refer you to the specific doctors, and we will try to discuss with you what are the appropriate alternative of blood thinner for you, Mr. Wong.
All right. Now you see, I'm actually have some chicken to be fed at home. So when can I actually be discharged?
On the discharge part, I think we will try to stabilize you first prior to discharge you, and hopefully that you can contact your family, or we can send some social worker to help you with this if it's okay for you.
Hands up.
Or okay. Question. So okay, doctor. Okay, doctor. May I know what is your diagnosis?
At this point of time, I would think that this patient is having an upper GI bleed, most likely due to over warfarinization. And
Secondary to overorphanization.
overorganization. And as the patient is also having a systolic murmur, I would also like to rule out any chances of a high D syndrome, which causing angiodysplasia in the colon as well.
Okay. All right. Okay, how would you like to investigate this patient?
This patient would need to be admitted to the ward acutely. To stabilize this patient, I think the patient would need a group and cross-match at least of 2 units of Paxel for transfusion. Subsequently, I would also request for a coagulation profile to look for any deviation in INR, which I can correct immediately. I will also request for a renal profile and liver function test, but particularly liver function test if the patient was a previous alcohol consumer to look for any evidence of liver cirrhosis. And subsequently, I would also like to request for an amylase to rule out any acute abdomen or pancreatitis to be specific.
All right.
Yeah.
So if at all this patient INR come back more than 10, how would you like to manage this patient?
This patient would need to be admitted to the ICU preferably, and also transfusion of blood product with fresh frozen plasma would be very important, along with an IV vitamin K administration as well. This should be referred to the intensivist along with a gastroenterologist. After we have managed to stabilize the INR, we can arrange for an upper and esophageal gastroduodenoscopy to look for any bleeding over the upper GI first. And if there is none, we might need to consider proceeding with colonoscopy as well.
Okay, besides transfusion with fresh frozen plasma, what other thing that you can give to the patient?
The PICC is one of the choice as well for reversal of warfarin.
PICC?
I think it's a precipitin complex. Sorry, I can't remember the full name.
Okay, it's PCC. So,
PCC.
all right. The patient did mention that about alternative. What do you think the alternative is suitable for this patient?
I think the alternative after the patient is stabilized, the alternative would be it could be a direct oral anticoagulation, which carry a lower risk of bleeding according to the studies, as well as it can also be more easier to take as there is less structural interaction and also interaction with food as well.
All right. Just now you mentioned about do you find any possible causes for this over-warfarinization in this gentleman?
I should actually explore more over the diet as well regarding his warfarin.
All right. What are the foods that can actually affect the INR, that can increase the INR?
Increase the INR would be the food has a high vitamin K, which actually antagonize the effect of the INR, which usually green leafy vegetables.
Increase the INR.
If increase the INR would be grapefruit.
Grapefruit, some more?
If I'm not mistaken, St. John's wort.
Okay, some more?
I couldn't list any further than this.
All right. Okay. Just now you did mention about Haley syndrome.
Yeah.
Okay. Can you tell me a bit about Haley syndrome?
It's actually an acquired ADAMTS13 deficiency due to underlying aortic stenosis, which can be presented as GI bleeds, usually in the colon.
Do you think this patient have aortic stenosis?
Pansystolic murmur usually points towards mitral regurgitation.
Okay.
Myself, you can continue.
All right. I think it's okay. So yeah, doctor, how do you feel?
It was totally different from my list of differential diagnosis when I go in actually. That's why I got a bit shocked after this.
Yeah, what is actually written on your paper? The differential?
Initially, I thought it was either heart failure, liver failure, or kidney failure. Anemia was part of my differential actually. And I was thinking also because the patient has a low blood pressure, probably they might be having some septic shock or some infection ongoing, infective endocarditis or something like that. Also endocrine part, I think of adrenal insufficiency or hypothyroid actually.
But 2 days history lah, 2 to 3 days.
Yeah,
So
yeah.
Addison, yes, but 3 days short history, you always need to think of anemia, bleeding.
Yeah,
Bleeding.
yeah.
When the patient actually tell you he has AF, then you know that you have to really ask everything, every single thing about warfarin. You
Alright.
need to ask about the diet, you need to ask about the food, you need to ask about recent traveling, what was the previous INR, what was the last dose adjustment, any history of over-warfarinization, everything about warfarin you need to ask, because this is something very commonly come out in the exam. Usually what was expected outside is different from inside. So it's very, very important. Okay, so technically for the history, I feel like you can do better because you actually spend asking some redundant question about the lethargy and also the shortness of breath, because I think you don't know what else to ask for the lethargy. That's why you kind of like repeating your question already. So that part actually eats up some time. So if you can just ask some question like, okay, is it the same throughout the day? Because it's only 2 days. It's not something chronic. It's not like chronic fatigue syndrome or something that is more systemic that causes the lethargy lah. So usually very acute one, you need to think really think hard of bleeding, dehydration, or the volume loss rather than something more systemic. So if lethargy nothing much, you need to move on fast. So you need to move on fast, and once you move on, you will start to know that if you ask earlier, probably if you go even a bit faster, then probably you can get the warfarin and also AF history even faster. Then you have more time, because what you are doing is that you haven't actually finished asking the patient, then you are actually start to examine the patient, because I think you know that you kind of like a bit lag behind. So it's not wrong. You can do that, because in the real exam, actually, indeed, if you really have some limited time, you can actually continue asking a question. Examiner will not stop you, just that it won't look very nice, because when you're focusing on examination, you need to think of what are the questions you want to ask also. So for this patient, why over-warfarinization? You didn't have enough time to ask about the diet. Am I right? So
Yeah.
if you have more time to ask about the diet, I will tell you that actually I drank grapefruit juice 3 days ago. Then that's the cause of the over-warfarinization. Okay. Then for the that's about the history. I think you actually took too much time on the lethargy part. You asked too much, and for this patient, it's very, very important. As you mentioned, you say that you saw the BP is low, and it's quite good attempt that actually put the patient on oxygen and asking whether it's okay to continue or not. Okay, it's some quite good attempt, but for your physical examination, when you see the blood pressure is so low, you can actually do a postural standing lying BP to look for evidence of postural hypotension. Then you will know your differential will be rather reduced to a few more. So it's very, very important in low BP, or you probably can just ask to do a postural. If the postural really drop, you know patient is either bleeding or adrenal or severe dehydration. Yeah. Then as I mentioned, this patient is pale. So it's pale. So good attempt in getting the murmur, but you are digging your own grave actually when you say it's Heidi syndrome. You say I told you it's a PSM, then you tell me Heidi syndrome. Okay, kind of like contradicting yourself is very dangerous. Try not to contradict yourself. AS and MR, the murmur is totally different. The location also different. Okay. Then as for your history part, I think you your systemic review is not too bad. It's okay. I would say okay. But you did miss here and there then the major chunk on the warfarin part lah. For examination, good that you examine about the failure symptoms all okay, no problem. You offer a DRE and it was a Malinix too. That one is good. But for your management and investigation part. Management for over-refinization always tell about PCC first. If PCC is not available, then only we are talking about FFP, because PCC is actually the gold standard. I already tell you INR is more than 10. So your immediate treatment is actually PCC, transfusion, PEG cell transfusion, and also you need to stop the warfarin plus minus vitamin K. And is OGTS a necessary? Is a must? Is it a must?
I think not in the acute situation.
Yes,
After we
you need
stabilize the INR first.
Yes, you need to actually stabilize the INR first. Once the INR normalizes, if the melanic stool or the upper GI bleed persists, then yes, you must do OGDS. Not really colonel, plus minus colonel, but OGDS is a must, because it's if the INR normalizes but the patient still, you are still suspecting ongoing bleed. So I think you need to read a bit more on the management, because even for PCC, we do have a triple, 3-factor or 4-factor. I'm not actually asking that yet, but you need to know a bit more about PCC. It's called prothrombin complex concentrate, and when should you use? What are the factors they are replacing? How do you monitor? How do you give? You need to know superficially, because in emergency you need to use that as well. If really don't have, then only we go for FFP, which should take longer. And how long after you actually give PCC you need to repeat the INR? That one is another question that sometimes they might actually ask you to see whether you know how fast PCC actually acts and works. Then about the resuscitation part, you always need to say stabilize the airway, breathing, circulation for this patient, because the BP is lowish. So definitely this patient needs fluid resuscitation, need blood volume replacement, and importantly, the patient did offer the history of his staying alone, and there are actually history of over-refinization. So when you discussion part, you need to think about alternative, which is the NOAC. Of course, not during the emergency, but you can need, like you mentioned, and say, okay, there are actually other alternative that we can discuss, and that can actually does not require frequent blood monitoring and has much lower risk of bleeding. So in view of you have actually history of this over-refinization, this is the second time, I think it'll be probably better if you can be switched with this medication. So in general, I think your history, I will give you a borderline, because you miss out the most important part, which is the diet. Physical examination, I will give you satisfactory, good. Clinical judgment will be borderline, because of the history you couldn't actually get, and also your management part will be a bit not steady. Managing patient concern will be satisfactory, and identifying physical sign will be satisfactory. Differential, actually for this differential, because it's so clear cut, is upper GI bleed secondary to over-refinization, secondary to the diet. So if you couldn't actually tell me that the diet history, actually this can directly go to unsatisfactory, because you didn't get the most important thing. You missed the most important thing that actually causes the bleeding. Then welfare, I think it will be satisfactory lah. In general, warfarin cases is very commonly come up in exam, and you really need to ask everything about warfarin and score lah. Because if you really cannot find the trigger or the event at the tip of the NR, basically the station you will be marked down significantly. Any question?
Okay, I understand. Thank you.
Jimmy?
Yeah, thanks. Yeah, I just want to ask, what is your should be Ben, right? What is your approach when you write in approaching a scenario of lethargy outside when you prepare a scenario?
To begin with, I think I write the heart failure, liver failure, and kidney failure. And then after that, infection, like infective endocarditis. followed by endocrine part would be hypothyroid and adrenal insufficiency, and then anemia.
I see. So you can see that it's like almost every system, right? So you are quite aiming towards all direction and asking all the systemic review. So perhaps just a quick sharing on, I mean, for exam purpose, which is also quite useful for practical purpose. So sometimes when an exam scenario came up with like lethargy, fatigue, or even tiredness, right? You can actually go by a few key questions to help you localize which area or which domain you're dealing with. So perhaps the first question is the variation, whether there's any diurnal variation. Like, is it tiredness only in the morning or towards the late evening or towards the end of the day? Because tiredness early in the morning, which may suggest some OSA kind of syndrome. Okay. However, if it's and also if it's like worse with the day as it goes, then it may suggest something like myasthenia gravis, right? And sometimes can also suggest Lambert-Eaton as well, depending on the variation. And then if it's like improve with the day, then you are maybe dealing with some form of rheumatological condition which actually improve the condition, all the stiffness, the lethargy, improve as the days go by because of the inflammatory nature, right? So that can give us your clue that which direction you're dealing with. Let's say it persists throughout the day and night, like in this patient, if you ask. So the next question perhaps you want to rule out is anemia first. Anemia is common, it's a commonest. So you want to straight away ask about anemic symptom. Anemic symptom, if yes, then you need to target for every orifices symptom to suggest any blood loss. Like in this patient, you will immediately clinch the diagnosis of there is a passing of Becky's stool. That can give you a clue that you are dealing with this. Okay, and let's say patient have no anemic symptom, and the next question that you want to ask is actually whether there's any weight change. Okay, because weight change or weight gain or weight loss will tell you everything about endocrine disorders. Let's say patient have weight loss. So patient have weight loss, then you're thinking more to hyperthyroid, you're thinking more to adrenal insufficiency or Addison disease. You're thinking more to can be chronic infections like TB or even RVD, can be also like malignancy. But if it's a weight gain, then you are dealing with more of hypothyroidism, Cushing disease, or even Cushing syndrome, acromegaly, or even like panhypopituitary syndrome. That can happen because you see, panhypopit is something that if you don't think about it, you won't really ask all the 5 axes, right? So, but sometimes commonly in scenario they can come out with just fatigue. It's very non-specific in a very difficult scenario, I would say. But this is something that if you go by this approach, you shouldn't miss this kind of important differential. So weight is another important thing. Like for this patient, if you ask the patient weight may be static, he doesn't realize anything, any significant change, and the appetite has been almost the same. So if the weight does not give you a clue, there's no recent weight change, then perhaps the 3 things that you want to focus is actually the rheumatological condition. You ask all the CDD symptom. The second thing is actually the liver disease. For example, PBC, primary biliary cholangitis, can be hemochromatosis, can be MAFLD, like fatty liver disease. These 3 can actually manifest as just tiredness or lethargy or fatigue. Okay, then you can also ask about kidney diseases, but it's not that common because sometimes they usually accompanied by a bit of itchiness, a bit of, for example, reduce in their urine output, or even like passing of frothy urine or blood in the urine, things like that. Then if you really cannot identify the cause of the lethargy, then you may need to think about whether you can deal with something is non-organic, like chronic fatigue syndrome or fibromyalgia. But you don't want to mention this like very beginning because this is one of the diagnostic exclusion after you exclude everything. So perhaps the more, I would say, more practical way to approach to fatigue syndrome is you ask about diurnal variation. Number 2, you ask about anemic symptom. Number 3, you ask about weight change. Number 4, you ask about CDD symptom. And then number 5, you ask about kidney and liver condition. And number 6, if you really don't have any good diagnosis and you ask on the mode. Let's say there is some mode symptom, there's a lot of functional impairment, lifestyle limiting factors, then you may want to think about like chronic fatigue syndrome, things like that. Okay, this is general approach. But this stem actually got two complaint, right? Another complaint is SOB, short onset SOB. So SOB can be cardiac causes, can be respiratory causes, or can be others like systemic causes. So you need to have two different differentials for two different chief complaints as well. So when you prepare outside the scenario SOB, you may want to differentiate into cardiac or respi or even others. Okay, others as systemic, as in like anemia, like for example thyroid disorders, for example as the usual one, kidney, liver, things like that. So when you look at this blood pressure also, this will give you a clue the PP is low, although there's no bradycardia or tachycardia, and the SpO2 is like only 94. This gives you a clue that the patient may not stable to begin with and may need admission. Okay, and with this kind of blood pressure, definitely I would think hard towards blood loss. And this is when I prepare the scenario outside. And I will definitely remember, I will write on the piece of paper in case I forget. When I examine the patient, I will ask for postural BP. This kind of scenario is important for you to really know whether patient got any postural drop or postural hypotension. And it's not enough to just ask about symptom like postural dizziness. It's not enough. You really need to go and examine the patient and say that I want to check for the postural blood pressure lying and sitting. If there is postural drop, then you know that probably the like what Yihong said, your differential diagnosis actually narrowed. You know what is the possible differential diagnosis of postural hypotension? Ben?
Adrenal insufficiency can be one of it, and
Good. Yep. Another one?
I think it's
In this scenario, anemia, right?
or in this scenario, yeah,
Any other differential for postural hypotension?
autonomic dysfunction, like
Good.
DM,
Like what? Sorry, like diabetic
in diabetes,
autonomic
yeah,
nephropathy, right? And
yeah,
another
and the
another
multiple
cause of
systemic,
MSA, right?
systemic,
Like
yeah.
the previously known as Shine-Drager syndrome, right? Okay. Then any other differential diagnosis other than these three?
I think heart failure can be one of the
Heart failure, not really, because sometimes it's difficult to perform also depending on the EF, right? Whether there's any diastolic dysfunction, right? So another two is important you need to exclude is drug and dehydration. In this patient, definitely the dehydration anemia contribute to it as well. So DDAAA, you must make sure that if let's say a patient that have postural hypotension, you want to make sure you're not dealing with any drug causing postural hypotension. Drugs such as antihypertensive, drugs such as like alpha blocker in those patients with BPH, and then the another D is actually the dehydration. Want to rule out any blood loss, any volume loss, any GI losses, for example, vomiting, or even like diarrhea. Okay, and then the 3A that you mentioned, anemia, adrenal insufficiency, as well as your autonomic dysfunction, especially in a patient with diabetic. So you want to know their control, their sugar control, whether it's okay, and whether there's end organ damage, like for example, the eye, the kidney, as well as the nerve. Okay, so yeah, so that's a approach that I feel is important because in exam it's impossible for us to ask all systemic review. If we're going to really spend a lot of time for your timing, right? At 7 to 8 minutes, you still haven't really confirm that this is a GI bleeding per se. I can see that you're still going through the systemic review, which can be a bit dangerous. When your history reaching about 6 to 7 minutes, right, you should have a differential already, and it's quite sure already. Once you confirm a differential, perhaps the next thing is to really look for complication and the severity. And you also start to think that what else that you want to examine. Oh, in this patient, do you mention you want to examine for per rectal examination? Because in case I miss out about it.
yeah, I did. And there's the one which gives me the answer actually.
Did you mention?
Yeah, I did.
Good. Because when the examiner calibrate this scenario, I'm sure they're going to calibrate about digital rectal examination. And they will also calibrate about features to suggest anemia, like postural hypotension, clinical, like pallor. Okay. And also in this kind of patient, upper GI bleed, you also want to really examine the abdomen to look for any stigmata of chronic liver disease. You need to mention as well. Okay. When you present, there's no stigmata of chronic liver disease, which may suggest cirrhosis. Because cirrhosis patient, if they are on warfarin, the bleeding risk is even higher. Oh? And you need to know the cause, like what Yihong said. So in patient with warfarin, drugs is actually basically just the conventional drugs, and supplements, including vitamins, including some herbs. Okay, and another thing is the hormone. Okay, hormone is include the thyroid, because you know that hyperthyroid can actually cause prolonged INR, Hypothyroid can actually reduce in the INR. Okay, and the drugs part, you need to really know which one is enzyme inhibitor and which one is inducer. Central wood, you mentioned that can cause prolonged INR, right? Which is wrong, because central wood is actually reduced INR because it's an enzyme. It's actually the enzyme stimulate inducer. So when the enzyme inducer uh, reacts in the body, it actually reduces the enzyme to metabolize the warfarin. Sorry, enzyme inducer will increase those enzymes that's supposed to metabolize warfarin, and therefore the warfarin effect will diminish. Same goes to vitamin K containing supplement like all the multivitamins. So it's important in this kind of warfarin scenario, right? You must ask about diet. You must ask about supplement. Okay, I know you all will ask about drugs, any change of drugs, any addition of drugs, but it's not enough. You need to ask about diet. Not just ask about green leafy vegetable, which will cause the INR to be low actually. So you need to ask something like grapefruit juice, any like any other fruits, especially the citrus fruits, that can actually cause the INR to be prolonged. Okay. Another thing is the supplement as well as the over-the-counter medication. For example, NSAID. Sometimes antibiotic medication can also cause. This is important to ask. And when you in your management, right? I don't recall you mentioning about GXM. Do you mention about GXM, cross match of the blood?
I think that is the first thing I mentioned.
Yeah, we do it routinely, but in exam we don't mention at all. We need to mention every reading circulation, take the bloods, insert a large ball cannula because it's acute management, acute upper GI bleed. So your management must be acute as well. And then I also remember to send for cross match group screen and cross match. Make sure to transfuse the patient, stabilize the patient. In depending on the INR level, I will also consider to give patient PCC, which is a partial prothrombin complex concentrate. So that will actually give you a clue. And in terms of whether or not the upper GI bleed, do you know how to how do you prognosticate upper GI bleed?
What scoring system?
I thought Yi Hong will ask this, so I said okay, but
Exactly.
he didn't ask you, so
What
I
scoring
thought.
system?
Do you know?
I cannot recall the moment.
There's two, right? One is for prognosis, and one is to determine the mortality. Do you remember?
Something like blood.
Yes.
Yeah. Which is
I can't recall the full detail actually.
so remember in upper GI bleed there's something like GBS lah, like but it's not Guillain-Barré lah. This is actually Glasgow Bradford bleeding score lah, Glasgow bleeding score lah. It's basically to satisfy high or low patient that need scope or not. Okay, so because higher GBS score, we will suggest that the risk of mortality is higher. Okay, do you know another score?
No, I have no idea. Or the forest score, forest outside.
Yeah, I mean forest is the endoscopic finding lah. Okay.
Yeah.
Okay, but it's okay. Usually we don't do that. I mean, if you go to other center, international, other than Malaysia, I think they will ask about this because Malaysia we seldom use that. But actually, gastro people will ask about that lah. So just in case your examiner is a gastro consultant, then they may ask about that. Okay, you need to know about this. And anything else to add on? I think that's all right. You.
Yep.
Yeah.
Everything.
Anyone got any question? I think someone want to speak right just now. No one. Okay, then perhaps we go to third scenario. Is it okay?
Yep.
Yeah, third scenario is Chris, right? Chris, are you there?
Hi, can you hear me? Hello?
Yeah. Okay, all right. So are you ready for the third scenario?
Yes.
Okay, so I will start the timer now. You have 4 minutes. The time start now. Okay, time's up. So yeah, Dr. Chris, this is the patient, Madam Josephine. You can start.
Hi, good evening. I'm Dr. Tay. I'm a doctor in the acute medical unit. My cohort is this Madam Josephine, 50 years old.
Yep, I'm Josephine, 50 years old.
Hi, I understand that you come for diarrhea for 4 months. Would you mind telling me more about this?
All right, I actually have been having this loose stool for the past 4 to 5 months, and it's actually getting worse because initially it's not happening every day, but for the past few weeks, it's actually getting worse in the sense that it happens almost daily now.
Okay, I understand. It must be very difficult for you.
Yeah.
May I ask, in a day, how many times do you pass your motion?
The least will be at least 3 times, and the most will be up to probably 6 to 7 times every day.
And this has been occurring for the past few weeks, is it you mentioned?
Yep, the worsening part actually for the past 2 to 3 weeks.
Okay. How about the initial, the earlier, the first few months?
First few months, probably about 3 times per day.
Okay. May I know the amount of the stool that you pass out?
Oh, it's usually minimal amount. It will be like getting little and little as I pass motion, the frequency is more.
Okay. May I know the color of the stool?
Yellowish to brownish.
Okay. Is the stool, after you finish your motion, is the stool difficult to flush?
Occasionally, they will have the sticky feeling.
Okay. I mean, is it difficult to flush?
Not really.
Okay. Sticky as in you mean there's some mucus, mixed with mucus on it, is it?
Yes,
Okay. Is there any tummy pain?
I do have some discomfort whenever I have this feeling of passing motion.
May I know at which area you feel
Or
discomfort?
at the lower part of the abdomen.
Is the tummy pain relieved after you pass your motion?
Yes,
Any vomiting?
no vomiting,
Any fever?
no fever.
Okay. Previously, may I know before the 4 months happened, may I know how is your previous bowel habit?
I used to pass motion at most 2 times a day, maximum.
Okay. Um, is there any uh sorry, wait, okay. Is there any loss of appetite?
No loss of appetite,
Is there any weight loss?
no weight loss,
Okay. Is there any body weakness?
no body weakness,
Any body numbness?
no numbness,
Any problem with your vision?
no,
Any body rash?
no,
Any swelling or lumps and bumps on the body?
no,
Okay. Is there any chest pain?
no,
Any feeling of heart pumping very fast?
no,
Any shortness of breath?
no,
Any problem with sleeping with lying flat?
no,
Any problem with waking up at night catching a breath?
no,
Okay. Any problem with your urination? For example, any pain or any change in the color?
no,
Okay. Is there any muscle pain or joint pain?
no,
Okay. Is there any mouth ulcer?
no,
Is there any eye redness or eye pain?
nope,
Is there any hair fall?
hair fall, no.
Okay. Um. Okay. May I ask, Madam Josephine, do you have any past medical condition that I should be aware of?
Uh, I don't have any problem prior to this.
Okay. Have you been hospitalized for any problem before?
No,
Have you underwent any kind of surgery before?
no,
Okay. Are you currently taking any medication?
I'm actually occasionally bought some medication to stop the diarrhea actually, but it works on and off. Sometimes it's actually not really helping also.
Okay, may I know the name of the medication?
I think it's called Lomotil.
Okay. Before the 4 months before the diarrhea occur, do you take any medication before that?
No,
Okay. Um, may I ask, do you have any diseases running in the family?
my brother do have they told me was intestine cancer, and he actually did the operation.
Oh, I see. May I know at what age your brother has been diagnosed with intestine cancer?
It was rather young, probably about 45 years old.
Okay. Is there any other diseases running in the family apart from your brother?
No,
Okay. And how is your brother doing?
my brother is doing well now.
Okay. Okay. May I ask, do you smoke?
Oh, I never smoked in my life.
Okay. Do you consume alcohol?
Occasionally during festive season.
Okay. Sorry, the following question might be a little bit sensitive, but this will help me to get into my diagnosis. May I know, do you consume any illicit medication, illicit drugs?
No.
Okay, thank you. May I ask what's your occupation?
Oh, I actually am a housewife.
Okay. How many children do you have?
I have two children.
Okay. Is there any problem with miscarriage before this? I mean, losing miscarriage.
No.
Any abortion? No. Okay. May I know when was your last period?
Oh, actually, I have menopause 2 years ago.
Okay. Are you currently taking any hormone replacement pill?
No.
Okay. Okay. Um. Okay. I would like to proceed to examine Madam Josephine.
All right.
I would like to examine the general well-being, general appearance. Is she big size or small size or slim looking or caucasic?
She is she looks thin, but she's not cactic.
Okay. I noticed the heart rate is 100. I want to palpate the pulse to look for any regular or irregular in the pulse volume.
Regular pulse with a good pulse volume.
Okay. Any so I will check the tongue. Any dry tongue or dehydrated tongue?
She looks slightly on the dry side, but not like super dehydrated. Slightly reduced only the hydration status.
Okay. Any conjunctival pallor?
No conjunctiva pallor.
Okay. I will check the tongue for any candidiasis.
No candidiasis.
Okay. Any cervical lymph node felt?
No cervical lymph nodes.
I will go to the abdomen examination. I will check is there any distended abdomen?
No distended abdomen.
Okay, I'll palpate the abdomen. Is there any tenderness?
No tenderness.
Any mass felt?
No mass felt.
Any or hepato or splenomegaly?
No organomegaly.
Okay. Um. Okay. Madam Josephine, may I ask? Do you have a recent travel?
No recent traveling.
Okay. Do you have any problem with your just now you mentioned that you have no problem with your urination, right? Do you feel like any bubble in the urine?
No.
Any waking up at night, go to toilet to urine?
No.
Okay. May I know how is your diet like?
I actually taking mixed diet. I take meat and also I'm actually taking vegetable.
Okay. Do you notice any particular meal that will cause you to have diarrhea?
Initially, I thought I have some intolerance towards the the gluten, but subsequently I did try on some gluten diet. Then, but it's just similar. It's not actually getting worse.
Has there any blood found in your stool?
No.
Okay. Mm, okay. Um. Uh. Okay. May I ask, Madam Josephine, may I know what is your concern?
Is this a bowel cancer like my brother?
Madam Josephine, at this moment, I'm still, I'm still unsure whether this is a bowel cancer or not. But um, this is way back on my list of a possibility that you might have.
Mm-hmm.
So I would need to do some tests on you first before concluding whether it is a bowel cancer.
Okay. Do I need a scope?
Given that your brother has a history of cancer before and you have symptoms now, I will recommend you to do a scope
I
in the near
see,
future.
but I'm actually quite worried about the procedure.
2
Is there
minutes left.
other alternative beside the scope?
Yeah, there are screening tests that we will do. We call it stool for occult blood, where we take your stool sample to look for any blood. If it's a positive, then it might or might not indicate that you have a bowel cancer. Then we'll do a camera test to your lower colon, to your bowel to rule it out.
All right, I
Then
see.
there's also another blood test, the call tumor marker they call CEA, that will be helpful also in determining whether you have a bowel cancer or not.
Okay.
Is there any
So
other concern?
what do you think I actually have? Because this diarrhea has been bothering me so much now. I feel quite worried to go out from the house now because I keep need to look for a toilet.
Um, I was thinking the possibility of a disease called celiac disease. This is a problem where your body cannot tolerate a certain meal, especially gluten-contained meal. Then your body fail to digest the gluten-containing meal, then it will cause you to have a very bad diarrhea.
Mm-hmm.
But I understand that you mentioned that you try even gluten-free or gluten-containing meal also it doesn't make a difference. Yeah.
Okay, okay. So yeah, is this condition curable?
It depends on what's the diagnosis that I find in the end. Then I will be able to tell you whether it is curable or not.
All right, I see. Okay, I think yeah, that's all my concern.
Okay, time's up.
Okay, so yeah, Dr. Chris, may I know what is your provisional diagnosis for Madam Josephine?
My provisional diagnosis for this patient will be number one, celiac disease. My
Okay.
differential diagnosis for this patient will be number one, Crohn's disease, and number two will be colonic cancer.
Okay, anything else?
Um, can't think of anything on my list. Initially, I thought it's hypothyroidism, but I couldn't elicit any sign and symptom of hypothyroidism from history. And then
Okay,
endocrine-related problem also, there's no diabetic, and
okay,
there's no significant drug history, so I can't really rule anything out. I mean, I don't have any other differential.
okay. Your investigation of choice?
My investigation of choice will be number one, FBC, CRP, ESR, basically to look for infection.
Mm-hmm.
I will do a stool for occult blood, then
Mm-hmm.
following by a stool culture, stool for oval and cyst. And I will also send a effective screening. Yeah, I forgot to mention. I forgot to explore about the sexual history. Yeah, I will do a effective screening,
Mm-hmm.
and I will do a CEA, serum CA as well to look for any colonic malignancy. And following by if let's say a stool for a couple is positive and patient is keen for a colonoscope, because she say previously she's very worried. If patient is keen in future, I will arrange for a colonoscopy for her and to look for any masses for biopsy and for send for HPE.
Okay, so if let all the diagnosis is celiac disease, what would you expect in your full blood count?
If it's a celiac disease, I would expect to see microscopic microcytic hyperchromic anemia. This is
Okay,
related to the iron deficiency anemia.
Summer
And
from the white count,
total white count,
the differential count.
the field count will be raised.
All right, good. Okay, so any other blood investigation that you would like to take?
I will take a renal profile because she has a significant diarrhea. I would like to look for any acute kidney injury. I'll send the electrolyte as well to look for any electrolyte imbalances. I will send iron study.
Mm-hmm.
I will also send the serum vitamin B12 folate related to the celiac disease causing the vitamin deficiency.
Mm-hmm.
Um,
Okay, how would you like to manage this lady condition?
Okay. Short-term management wise, I would admit the patient because she showed signs of dehydration and the heart rate is borderline tachycardia. I will admit her and I will carry out full resuscitation
Mm-hmm.
until the hydration status is restored. Then I will send the test that I mentioned just now to rule out the causes. Then long-term management wise, once you confirm it's a celiac disease, patient education and counseling and a multidisciplinary approach involving the dietitian for gluten-free diet and the gastroenterology team to manage the celiac disease.
Okay.
And also the education on the disease progresses and the importance of compliance to the gluten-free diet.
Okay, so if this is not a celiac disease, let's say it's also not a malignancy, if it's a Crohn disease, what other history that will be more suggestive for a Crohn disease?
I think I missed out just now. I would like to ask for any fistula, any mouth ulcer. No, I asked mouth ulcer. There's no mouth ulcer. Yeah. Okay.
Yeah, some more,
Uh,
something quite important.
jaundice.
No. Okay.
Not sure.
If this is the other possible differential, actually it could be a IBS, so irritable bowel syndrome. Do you
Okay.
know any criteria for irritable bowel syndrome?
Criteria, I'm not sure. But usually send a serum calprotectin. Sorry, fecal calprotectin to rule it out.
Fecal calprotectin, good.
Ah.
And what will be the management if it's a IBS?
Thanks, up, but continue.
It depends on the whether it's a diarrhea subtype or constipation subtype. So if it's a diarrhea subtype, I will manage according to the symptoms, giving her anti-motility and also referring her to explore for any psychological stress, any stressors, and deal with it by referring to a counselor and yeah, I think that's all that I can think of.
So, okay, technically, I think diarrhea, your history is insufficient because for diarrhea, the quite important thing is actually you need to know whether this is the osmotic diarrhea or secretory diarrhea. So, a very important question that you actually didn't ask is actually whether that the patient have any nocturnal symptoms.
Okay.
Yeah, nocturnal symptoms is very important when you have diarrhea. So because IBS, patient will not have nocturnal symptoms. Nocturnal symptoms usually can be seen in IBD or even malignancy. So it's a very, very important question. Do you actually wake up in the night after you actually fall asleep, that you actually need to wake up in the middle of night to pass motion?
Okay.
It's a very important question for diarrhea. Tenesmus, did you actually ask about tenesmus?
No, I didn't.
Tenesmus also very important for malignancy and also IBD. So you see your diarrhea history is not deep enough. So
Okay.
for diarrhea itself, the duration is good. Is it getting worse? Uh, is it what is the how many times the frequency increasing? What is the characteristic of the stool? Luckily, in the end, you actually asked me back any blood in the stool and the association, any crampy abdominal pain, any mucus, difficulty in flushing. That one you asked. Any tenesmus or incomplete feeling of sensation of incomplete passing motion, and any incontinences, uh,
Okay.
any like I mentioned, any nocturnal symptom, all are very important. I feel like you actually have more, actually some extra time because you don't know what else to ask really. These are actually all the important questions that you need to ask for diarrhea, because
Sure.
diarrhea itself is very huge. It involves technically almost a lot of system can present as diarrhea. So the negative for this patient is, okay, she has no constitutional symptoms. There are no weight loss, no loss of appetite. You did ask about fever, no hyperthyroid symptoms, no OTC, TCM. But something that is important is that for this patient, you ask about IBD per se. You did explore a little bit about extra intestinal manifestation. You asked about some joint pain, all which is good. But for the traveling, yes, you did ask about traveling, any what we call it, any recent traveling, any medication exposure, but try to be more specific, any antibiotic exposure. Although
Oh,
I understand C. diff could be a bit too long for 4 months. And very, very importantly, our RVD patient also present with diarrhea, chronic diarrhea,
yeah.
our HIV patient. So that one you need to ask. In tropical country in Malaysia, TB, colitis, also quite common. So you need to ask about TB contact. You need to
Okay.
ask about any night sweats or even hemoptysis. So technically, you miss rather a lot important uh, question that must be asked. Okay,
Sure.
then your red flags, when it comes to diarrhea, your red flag will be more than 50 years old, weight loss, hematochezia, family history. So actually, she does have some red flag. She is more than 50. She ngam 50, and there is actually family history of CA. So yes, she actually warrants a scope technically. So because she has
Okay.
flex. So for examination, if a diarrhea patient, if outside and inside after you ask, you didn't actually manage to get any symptoms suggestive of IBD, technically the examination could be rather normal. So you need to check for hydration status. And again, this patient is having frequent loose stool until uh, diarrhea. So I mean diarrhea. So you need to check the BP as well, because just now I mentioned dehydration can cause postural hypotension. So I will actually expect you to do a postural BP, and
Mm.
any neck swelling suggestive of a hyperthyroidism. Sometimes they might not have the symptoms, but of hyper, but actually they are hyper. And also the celiac disease part, the gluten diet is actually something to confuse you. I want to confuse you because again, yes, celiac disease can happen in this age group, but it's not that common. Yeah. Then once you check for mouth, okay lah, you probably should check for more for iron deficiency sign also, and you need to quickly check through the abdomen, and please auscultate the bowel sound.
Okay.
Yeah, you need to auscultate the bowel sound. So for this lady, actually the differential is IBS, IBD, or malignancy. Celiac will be probably very, very down my list lah. I agree lah. It can happen, but it is not that common in our Asian population. And your center probably is a Asia center, so it might not be that common lah. Of course, if you can say is your differential, yes, we won't penalize lah. And for your investigation, because I think your direction is slightly different, slightly deviated a bit because your focus is a bit more on celiac. So, and yes, you mentioned about all the stool and also the biopsy all. But if you think it's celiac, something else you can send, right? The serum.
Yeah. Transglutaminase antibody.
Yes. So if you think that that's the diagnosis, you need to back up yourself with something else that is more gold standard. Okay. Then for IBS, yes, you mentioned about fecal count protectin in the end, but did you mention about TFT?
No.
Yeah, and biohazard screening in the end, yes. And ESR, CRP, TB will are an abdominal X-ray at least, because it's a persistent diarrhea. You still need to do an abdominal X-ray. And the management part will be likely depending on your diagnosis. So for me, I will label this lady is likely to be having IBS, because if you have get more history, actually she got all the negative like tenesmus on and off, yes, but tenesmus can happen in IBS also. So if it's IBS, the criteria is actually called room 4 criteria, ROME, room 4 criteria for IBS. And there's another criteria called Manning's criteria. You can go and have a look. So you need to know the superficially lah. You need to know the name, because I don't think the examiner will actually penalize if you cannot tell also. So the management will be depending on the subtype. So for her, is if it's IBS, it's actually the diarrhea subtype. It's not the mix, because she got no constipation at all. So the management will be anti-diarrhea, bowel acid sequestration, and something more high-fi is called iloxadoline. You no need to actually need to know is something extra, but antispasmodic, yes, and if at all it is still cannot control, you can consider antidepressant, TCA. So especially tricyclic antidepressant, which is can help in this IBS. So if it's IBD, the management will be depending on whether it's ulcerative colitis or even Crohn's disease, because it will be slightly different. Crohn's disease, if a fistulating disease, must be biologic ready. For ulcerative colitis, you still can use suppository mesalazine or even mesalazine also. It's totally different. So for malignancy, the treatment will be depending on the staging all. So is this a bowel cancer? The patient concern is because the family history and the red flag? Yes, you cannot 100% rule out. We are sending tumor marker, and if you think that since she had a red flag, yes, she probably need a scope, and you need to take, if you cannot find anything from the like some mass, you need to take random biopsy also. Any alternative beside the scope, probably blood test, but the gold standard will be a scope lah. Is it curable? IBS is not, it's not 100% curable, but it's treatable. IBD is not curable, but it's treatable. Malignancy, depending on the staging, it potentially can be curable. So for you, in order for me to mark you, I think your history part, I can only give borderline to actually low borderline, going to unsatisfactory, because of you actually miss out quite some important parts for the diarrhea. And physical examination, I will also mark you a bit down, because you actually didn't check on the neck and everything else. Clinical judgment also will be borderline. The concern, yes, I can give you satisfactory. Physical sign, since the physical examination is already marked down, the physical sign definitely will be down itself, and the differential will be also down because you focus more on the celiac and you didn't actually manage to give me the differential of IBS, and the welfare will be satisfactory. So it's just a borderline station. It's actually quite dangerous. I mean, same like the station just now, warfarin station. If you can get a diarrhea station, you really need to ask everything about diarrhea. Just like the warfarin, you really need to ask everything about warfarin, because it can be very simple if you tackle it correctly, but it can be disastrous if you actually forgot to ask the important question. Something like insulinoma all can actually present with diarrhea also, or the neuroendocrine tumor. So that one you really need to ask even deeper. Okay?
Okay.
Yeah. Jimmy?
Okay. Thank you. Thank you.
Yeah, I mean, this kind of scenario actually came out a few times, not just once or two. It can be very common. You'll be surprised that things like IBS, things like, for example, what other thing condition, for example, chronic fatigue syndrome. You know, those kind of diagnoses that we always think is the down. I mean, it's the bottommost of the diagnosis, but sometimes they actually want to test our knowledge in excluding the differential. So meaning to say all the red flags you must be very familiar. Like for example, what is the red flags of the GI point of view? You must really ask for all the red flag. You cannot miss any of it, because without excluding all the red flag, you cannot commit a diagnosis. Just like this is a typical scenario. So a lot of candidates face this kind of situation in which the scenario can be like diarrhea, can be abdominal pain, or can be something like difficulty to swallow. So regardless of what GI symptom the chief complaint is, you need to really rule out all the red flags. Okay, so the red flag ranging from the age, ranging from family history of GI malignancy, ranging from difficulty to swallow, pain on swallowing, early satiety, in which in the layman's term we ask easy fullness after eating despite not much of food. And then you also ask about weight loss, unintentional weight loss, and also appetite loss. You also ask about any bleeding from the any vomit, any like, do you vomit, and does your vomiting content appears brown, and do you notice you pass any blackish stool? Do you notice pass any blood in the stool, for example? And then you also ask about any tummy discomfort, tummy distension in particularly, because you want to, in a way, your history is trying to look up whether there's any mass to begin with. And then at the lower GI part, the two important things that Yihong has mentioned is to rule out proctitis as well as tenesmus. So proctitis will actually means that you will feel easy. Proctitis is something like what you call how do you ask in the layman term is that proctitis is you will feel easily go to toilet easily despite unable to no, that was tenesmus. Tenesmus is incomplete emptying despite you go to the toilet frequently, right? So proctitis is more to like urgency like that. So you always want to rush to the toilet, and then you also have this irritation. So you must ask about these two, because that can suggest more towards like things like ulcerative colitis or IBD in particular. So you also want to at the same time also want to highlight the fact that all these red flag that I mentioned is not complete without asking and without assessing whether patient got anemia as well as jaundice. So anemia and jaundice is also one of the red flags that we easily miss. Sometimes when you ask question, you ask, you won't typically ask about anemic syndrome. You may ask, but jaundice is something you may miss also. Then when you examine the patient, it's also important to really look hard for the eyes to look for any conjunctival pallor or scleral jaundice. Is important. All these are the red flags are important. Let's say in this scenario, you know that you can't really find the red flags. Yes, this scenario will be very cautious. Generally, when we do a scenario, right, in the clinical consult, when the patient asks you, what do I have? And in your mind, your diagnosis is like 50-50, you really don't know which one is which one. I think that's fine in a way, but generally you will try your best to really identify which is your diagnosis. Like for example, in your history, right? Let's say your history and examination really find out you cannot actually find any red flag at all. Cannot really find any red flags, and the examination is a normal abdomen examination. nothing of note. So you will mention something like and IBS is something we know related a lot to the moods. So if you know that you are going towards that direction, perhaps you need to focus more on the social aspect. Asking patient, do you have any stress in your life? How are you coping? Do you think is there anything that we can help you with? Ask about all those mood symptoms. How is your sleep? Sometimes all these things we hardly ask. And I can see that you really have a lot of time towards the end. I generally don't ask the patient what is your concern until the examiner hints me you got 2 minutes left, because it also gives us a cut-off point that we need to ask more and we also need to examine more. If you finish before 13 minutes, that means that something is missing or your history or examination is not complete, or you really do very fast like Superman like that. Whoa, do everything too fast. Cannot. So must be almost near the 30 minutes, right? Cannot be too fast. When it's too fast, you need to be very worried that you may miss out something important. Okay. This patient, I would actually offer to examine, to do a digital rectal examination as well. The reason is being want to know whether there's any blood in the stool. Sometimes the patient may not complain. Okay. And in terms of the diagnosis, when the patient asks you, what do I have, right? So if you are very uncertain, like 50-50, can this be cancer? You say it's actually possible. However, based on what you have told me and what I examined, it is less likely. But I cannot exclude for sure until we have a further workup for you. Sometimes you can just answer like that. You doesn't need to really give a very conclusive 100% answer that no, this is not cancer. We won't know for sure sometimes. Okay. Then let's say the candidate asks you, like, I mean the surrogate asks you is like, do you need a scope? Yeah, like what you mentioned, yes. Because to diagnose, let's say you're thinking towards IBS, right? You cannot really diagnose IBS without a scope. You really need a scope, okay? Unless in a certain situation that everything really point towards IBS and all the investigation has been normal, we accept the scope. In a young patient, less than 50, no red flag, yes, you can omit the scope, but generally, we will be very cautious when saying that, okay? And then alternative wise, any alternative as in, sorry, what was the question again on the alternative part, Yong?
He's asking alternative for from apart from scope, what else can be done?
Yeah.
Oh, okay.
and
Alternative test.
scope.
Okay, I see.
Yeah.
Alternative test per se lah. Okay, all right. So sometimes you also need to know a bit on the diagnostic criteria when we talk about IBS. IBS meaning to say all your investigation must exclude your differential, including hyperthyroidism. That's why TFT is also important. Fetal calprotectin, yes, can be important. Stool workout as well. Bear in mind that we also need to exclude things infective colitis. Sorry, I forgot the 4 months, right? So this is a chronic diarrhea. So chronic diarrhea is also important to really chronic diarrhea, right? Regardless of age, right? You must really exclude high risk behavior. I can't remember whether you mentioned about that. Do you?
I didn't.
Yeah,
It was-
it's important, huh? It's important because if you miss out high risk behavior kind of symptom from chronic diarrhea, you will easily miss out RBD and opportunistic infection. It is important part of history that you need to be mentioned as well. And then the rest of it, okay. So the examiner may ask you what is IBS, how do you diagnose? So you want to know about the 1, 2, 3, 4 thing. That's how I remember lah. So 1, 2, 3, 4, what is that? It's a room 4 criteria, and 1 and 3 is what? So it must have at least once recurrent abdominal pain, at least once per week, for at least 3 months. Okay, so what is about 2? And must associate with 2 out of 3 of the following, in which there is a relation in terms the pain must be related to defecation. And then there's also some changes in terms of the stool frequency, passing of motion, and also the stool form. So if 1, 2, 3, 4, you already kind of like know how to diagnose IBS, right? Yeah, IBD is something different. If you're suspecting IBD, you should expect more symptom, more things to exclude. And IBD to diagnose it is not enough. You need to make sure that you're not dealing with primary sclerosing cholangitis, for example. You are not missing any anterior uveitis, any eye redness. I know you asked about all that, joint pain, connective tissue syndrome. It's important. Again, but don't be too contented if you think the patient have IBD, because IBD actually predispose the patient to develop colon cancer. So it's also one of the important things that you really need to kind of like include the malignancy part under your differential, because sometimes we all know about all this predisposition, and it's also important that if the scenario is moving towards GI malignancy like colon cancer, we need to, I mean, the family history is something very routinely asked, but you also need to give an idea that what are the possible familial hereditary malignancy syndrome for GI. For example, FAP, HMPCC, and for example, there's another thing that is actually Leller, which is a Peutz-Jeghers syndrome. I mean, it's rare, but something we tend to mention as well. So these three syndrome is something is important as well. You need to know about what is the Amsterdam criteria. For example, for the HMPCC, to exclude the FAP first, then this is a HMPCC. Let's say. So diarrhea is not easy, but there's a lot of criteria, but generally you just need to know a rough criteria. So the diet is also important. Perhaps I wouldn't talk about pharmacology. I will talk about non-pharmacal. Let's say this IBS, you need to talk about FODMAP diet, low FODMAP diet. Those diet that contains less complex or so-called oligo or all those sugar-based food that can actually cause a lot of irritation. Low FODMAP diet. You want to advise for low FODMAP diet, and then you want to consider starting medication, which is including like amitriptyline, which is like one of the tricyclic antidepressant. Okay, so you want to mention about that, and if you're thinking towards that line, perhaps you should also mention that baseline ECG as well to avoid missing a prolonged QT, something like that. But this is all generally, I would say, something very additional. Like, it's not important. The important thing is not about the high-fi stuff, but back to the diagnosis. You cannot give a 10 differential diagnosis for a diarrhea, a chronic diarrhea, but you cannot commit to one, because examiner actually want us to assess one by one which one is the most likely diagnosis. And that's I would say that that's the very difficult scenario, because you need to be confident at the same time. You really need to make sure you didn't miss out any warning sign at all. So it takes a bit of gut as well as a bit of I would say technique to really exclude all the red flags, and then only then you can commit. Okay, because this kind of scenario easily can kill a lot of people. Easily can kill a lot of people. Let's say you commit that this is cancer, but actually there's not much of sign. You cannot justify yourself. As examiner asks you, what do you think this is more likely cancer? There's no red flag. Then you know that perhaps you are not in the correct track. Okay, so that's all. Yihong, anything you add on?
Yeah, I think the scenario today probably is something that you normally see, but in exam situation, you can easily miss a diagnosis.
Yeah, agree. Yeah. So I'm just wondering, last scenario, anyone wants to do a last scenario? Anyone like willing to try or going for diet too? Because if not, I think it's 10:30. So if you all feel like tired, then perhaps we can we can omit the last scenario. But I would feel like the last scenario is also equally interesting, because quite some time that scenario didn't turn up already. So it's also important. I think we just have to go through lah. But anyone wants to try, especially those that attended as an active today?
If not, then we can leave for next time also lah.
Yeah. I think Yihong was tired already.
Because the case actually, I think better to try as a candidate.
Yes, I will agree, because this is not an easy scenario. The last scenario is not easy.
Better to try as a candidate because you will know what to ask.
Yeah, agree. Yeah.
Mm.
Okay, so if no question, I think everyone is also tired. Pre-holiday night. Hope that no one is on call tomorrow except me. So yeah, I mean, generally, to just a short summary, I think today the scenario, to be honest, is not difficult, but you can see that we will face a lot of difficulties because then our basic preparation skill is not enough. Then we will have troubles in which we have difficulty to get into our diagnosis. Our approach seems to be not helping much, especially in getting a scenario of very vague kind of presentation, for example, lethargy. So we need to really have our approach, and you need to really go very systematic. And therefore it's important, whatever things that you write outside when you prepare, it's important that you write it properly, because when you go inside, you are very busy in asking all this question and then to try which direction is that. And most often or not, whatever things that we write outside may eventually turn out to be totally different thing, like just now it happened. So it can be something usual. So the principle is we also have to prepare the exam beforehand. A lot of scenarios, a lot of approaches actually can be prepared prior to going for exam. So that's why it's important. Let's say you have to brainstorm yourself, chest pain, what is your differential? Let's say, for example, like abdominal pain, what is your differential? Let's say, for example, leg pain or even the ankle pain, things like that. What is your differential? You must have a bit on the approach. Whether, like, for example, all the joint pain, you want to try to differentiate between mechanical versus inflammatory, and then you want to rule out the warning sign. So usually if I very stuck, right, I don't have any good approach for any scenario, I will usually do that. I will do something like I try to differentiate. If it's like joint, I will classify as inflammatory or mechanical. And then following after, I will try to rule out any red flag. Like for example, what you mentioned, night pain. Night pain is something unusual. Huh? Patients shouldn't have any pain when you sleep at night. So night pain is something unusual. Bone pain as well. And then slowly you go from there. I know everyone knows how to do a good systemic review, but systemic review, it spends a lot of time, especially to get a correct diagnosis. You need something more effective. In exam, you need something more effective, and then so that you can think along as you go. And definitely, this is something that we can prepare beforehand. I think Yihong, very thankful for Yihong for preparing the scenario today, because I think the scenario he prepared is very relevant for exam. I am not saying that the scenario I prepared previously is like very tough, right? A lot of people feedback is like very tough scenario, but actually it boils down to the principle of approaches. I think everyone have to practice. The idea is really to practice. Try to practice more with the friends. We have a lot of scenarios that are already provided the PDF. You all can go through together. I think that's the real benefit when you practice as a candidate compared to listener or whoever attended today. The point of view from listener and active candidate can be very different, because it forces you to think and forces you to present yourself, and that's what we are at disadvantage as compared to other international candidates, because Malaysian generally are quite reserved. We don't present much, we don't say much words. So those that present too much also not good, because you tend to present overconfident, and you give a false impression that you may not be a safe one. But those that very knowledgeable but yet speak very little, then it's also not good. So you need to really practice to get a balance of it. Okay, Yihong, you got any last word to them?
No lah, practice more with your friend. You need to partner lah, actually. If not, you don't know what you are missing also.
Yeah. So you can see that is the only way to really practice is actually your friend can become more OCD, right? You will know what are the things that you miss, and then you can remind each other. That's a very important point. Okay. So with that, we will end our session. Thank you so much, Yihong.
All right. Thank you.
We'll stop the recording. Yeah.
Bye.
Thank you. Just turn off.